Hello, everybody. I'm Dr. Kevin Huguet. This is Dr. W. St. Julian, and we're coming to you live from the Minimally Invasive Institute of Surgery, Weight Loss Institute. And today we're just going to have a lively discussion about our program and different questions that come through in regards to weight loss and bariatric surgery. So Dr. St. Julian and I are both fellowship trained in bariatric surgery or weight loss surgery, and both very enthusiastic about helping you through your journey for weight loss. So we're just going to start out briefly with a few true-false questions that we're going to throw out there, and as people join the discussion here. So I'll let Dr. St. Julian start with the first true-false question.
All right. So, true or false? Bariatric surgery can reduce the risk of obesity-related death by 89%. Also, just a reminder for people who are joining in as we go, if you want to watch this later, just use hashtag replay and you'll be able to see it again. Okay. All right. So, question number 2. Chronic sleep loss, extended periods of stress, and many prescription medications can also affect metabolism and lead to weight gain.
I can see that. Sleep loss definitely has a terrible impact on you, so hopefully should be.
And I think we've seen quite a bit recently with COVID and everything that's going on, the impact of stress on weight.
Absolutely. People are labeling it their COVID weight.
That's right.
Yeah. So it's understandable. You're not up and about doing your normal things. You're not burning your calories, and you're going to gain some pounds.
So at what point should we answer these questions?
So we have some people saying true. So we have some people chiming in here.
Okay.
Yes, true, true. So we have 2 votes for true.
All right. So that's right. So the answer to both of these questions are true. It's really impressive the amount of impact that weight loss surgery has on overall health, including mortality, let alone specific things such as diabetes, high blood pressure, heart disease, risk of stroke, cancer, arthritis, sleep apnea, the list kind of goes on. So yes, a recent study by the ASMBS showed that the mortality risk reduction can be as high as 89%.
I can completely see that because after these patients lose a lot of weight, it's amazing to see how these illnesses are all reversed. And I think the one thing that is good to focus on is just one simple illness of diabetes, which can cause so many other illnesses and so much organ damage. So I can easily see how this study shows these results because I've seen it firsthand.
Yeah.
So I guess we've gone through some of these true-false. We can go on to some other questions to throw out there at the audience here.
All right. Question for the audience. When did Dr. Huguet decide that he wanted to be a doctor? Just put your guesses in the comments.
I guess you want to do multiple choice. I mean, let's say
in the womb, elementary school, middle school, high school, or college. Those are the options.
So we'll put that one out there. And then while you think about that, we'll ask, what about Dr. St. Julian? So what did Dr. St. Julian want to be prior to becoming a doctor? Put your guesses in the comments, and we could give you some ideas there. We can say a rocket scientist, a professional singer, a baseball player, or a football player. All right. And I guess we can wait for some responses on that. And I would say that I think Dr. St. Julian and I both feel that what we do is kind of a calling. So it's something that if your heart's into it, it's something you decide that you want to do relatively early in life, and once you, okay. So we have kindergarten, elementary school as a vote here. It was, I'll just say and tell you, it's actually, my answer would be middle school, was when I first decided I wanted to become a doctor. So it was something that, I felt like it, something that was very rewarding and something that I could see myself doing. So it worked out well for me. I really enjoy what I do. Do we have any for Dr. St. Julian questions?
Seems like there's a couple. A couple of folks say singer, baseball player. Yeah, so actually, I grew up playing baseball ever since I was very little, and that's really kind of what I always wanted to do. I really peaked at 12. We actually went to the World Series, the Little League World Series, before it was like a big
Wow.
televised thing.
I didn't know that.
Yeah.
Holy, that's really cool.
And then I hurt my arm, and the rest was downhill after that. So, but no, I decided to become a doctor actually senior year of high school. I was always interested in science and biology, and was always very curious. And that's kind of when I realized I excelled in it and naturally was interested, and there was really nothing else I wanted to do.
Yeah, I mean, I think you probably agree. I couldn't see myself really doing anything different than what we do.
Yeah.
Yeah, I think it's a very rewarding profession. And I think people are in the current times of crisis that we're in. They're appreciating doctors more and what we do. So I think it's a really good time to be a doctor. And I just heard on the news that applications to medical school are way up, which is good. I think that people are realizing it's a very noble profession that I don't think anybody will ever regret.
Yeah.
All right, well, we can move on here to maybe more kind of bariatric-oriented questions. And one question we have here is, what bariatric surgeries do we offer here at the Weight Loss Institute? And there are two mainstream operations, I would say, that are done in the United States these days. The most common operation is called a sleeve gastrectomy. And I think the second most common would be a Roux-en-Y gastric bypass. So we both offer the sleeve gastrectomy, and then Dr. St. Julian offers the gastric bypass. And I think we can let him comment on when he decides to offer that, because I think that's an important thing to cover in a discussion about the different operations.
Yeah, and I would say, I guess a third category is revisional surgery. So we're now at a point where bariatric surgery is so prevalent, and it's been around for a while, that we see patients who need revisions or some sort of repair after prior surgery for one reason or another. So examples of that might be if you have a lap band that's no longer functional or causing problems, that can be removed and transitioned to a different operation, or a complication after a sleeve or a gastric bypass for whatever reason. So we also offer that here.
And I think let's say most of the gastric or the bariatric operations we do would be the sleeve gastrectomy, and I would say that represents maybe 80-85%. And I think it's based more on its safety profile and its effectiveness. But the gastric bypass does play a role in the right candidates as well.
Yeah. And interestingly, the gastric bypass used to be the gold standard, and it was the most common operation. And then once the sleeve gastrectomy was discovered and the benefits of it were demonstrated, and the safety profile, etc., it is now, as Dr. Huguet said, the most common operation. But with the advent of increasing minimally invasive surgery and robotic surgery, the safety profile is significantly improved than what it used to be. So something that I do hope to do is, in those patients where it applies, really try to reassure them that it's a good operation.
So we have a question, and the question is, what are the potential complications? Which is a very good question. And so what we'll do is I'll go over kind of I think the complications with the sleeve, and then we'll leave Dr. St. Julian to talk about the gastric bypass complications. So two things that I focus on with patients in regards to a sleeve gastrectomy is known complications. Would be number one, the risk of a leak. And the risk of that is well less than 1%. So the likelihood is extremely low of it happening. But patients just need to be aware it's something that can happen. If it is something that happens, then it's usually handled by procedures where stents are placed or potentially more surgery. So it's a big deal if it happens, but most patients put their mind at ease because the likelihood is extremely low. So that's one. The other one that we talk about with the sleeve gastrectomy is reflux disease. And so that's something that we do have a pretty frank discussion about how bad it is now and the possibility of it happening in the future. And usually I quote a number of somewhere around 10% for patients suffering from it afterwards. And a lot of times with weight loss that will get better. If not, there's medications that we can start if need be for it. Sometimes if people have really, really bad reflux disease and they're finding some changes in their, say, their esophagus from it, then we may have a higher propensity to recommend a gastric bypass because that's actually a treatment not only for weight loss, but for also reflux disease. That's one of our indications where we would say maybe you should think about having a gastric bypass. So all in all, for the sleeve, those are the two things I focus on. Beyond that, there's risks to go with any operation. But if we're talking specific to these operations, those are the two. And so I think the sleeve has a really nice safety profile. Overall, it's just really, really a safe operation. And I've done a lot of different weight loss surgeries, and this is probably the safest one I think that we've had in comparison, say, like the lap band bypass, the sleeve, and then these other ones like doing a switch and things. So I think that that's why it's so popular, is because it is so safe. And people are very comfortable deciding to do that. And then in regards to gastric bypass, that's a little bit different.
Yeah, so the gastric sleeve is what we call a restrictive procedure. So you decrease the size of the stomach, and it has multiple effects that even affect hunger and blood glucose metabolism that all impact outcome beyond what you'd expect. So it's a very good operation. When we think about the gastric bypass, it's both the restrictive and the malabsorptive operation. So generally, gastric bypass will reduce an overall larger amount of weight loss. And when you put them together, each possible risk is actually very low, but there are additional things to think about. So similar to the sleeve, we think about a possibility of a leak. This was the dreaded complication in the past. A lot of times in the past, patients would leave a drain near the connection of the small intestine to the stomach. However, I would say right now, the literature probably states the leak rate is at highest 5%. In my training, the way I was trained to do it, certainly in my current practice, the people I train under and myself have a leak rate of 0%. Which in my opinion is becoming the norm, and the expectation is certainly what I strive for. So I think that the concern of a leak is much lower with more newer techniques, and there's no more placement of drains at the initial operation. Vitamin deficiencies is something to consider. So as part of the post-operative management, vitamins are checked and the patients take bariatric vitamins. Profound vitamin deficiencies are very rare, especially when within a program like ours. Something called dumping syndrome you may hear about, which has to do with the rapid transit of high caloric type food into the small intestine. That's something that can happen. However, it's best managed by diet. So within a bariatric program where you meet with nutritionists, medical weight loss specialists, and a lot of focus and education is put on the diet, incidence of dumping syndrome is actually pretty low. And some people even consider it potentially positive feedback type of a symptom, in that if you eat the wrong thing, you get a little uncomfortable dumping syndrome, and it gives you further encouragement not to eat that anymore. I think those are the kind of the big three. But altogether, each risk is still pretty low, but it is an increased number of things that we think about with gastric bypass when compared to sleep.
Yeah, I think that's a great synopsis of it. I think that the gastric bypass is a safe operation, and their patients do tend to have a fear of it because they may have a family member who maybe had some bad experiences in the past, but it is a safer operation done these days, particularly by Dr. St. Julian.
Yeah. That being said, we still generally aim for sleeve for patients who are candidates.
Yeah, I would agree. I would say our go-to operation for the most part is a sleeve, unless there are other indicators that maybe we should think about gastric bypass. So, I think that's generally how we approach it, unless, say, they have bad reflux disease, or if there's a big hiatal hernia, then maybe consider gastric bypass.
Right. And sometimes gastric bypass is also an option for patients who have had a prior sleeve and then develop severe reflux or weight regain.
So we have a question about self-pay. Our program is a very comprehensive program. So what we include with the program is we have a bariatric nurse practitioner who is also, we think of as a coach through the whole process. We have our patient advocate, who's Hannah. And so then we also work with a psychologist, an exercise physiologist, and a dietitian. So we really have a multidisciplinary approach. So there's a lot involved, and so for self-pay patients, all of these things are generally included. There's concern here about going to a how you doing?
Photo bomb.
Photo
Get down.
bomb.
Get down. Come on.
Going to Mexico, and the question was, what about going to Mexico? And I agree entirely on that. It is,
Sorry.
it is, I would think, a very dangerous thing to do. I don't, I've had patients come back and have issues that they couldn't get solved or resolved. But anyway, so yeah, I would encourage patients probably not to do that, and probably stay somewhere in the U.S. Self-pay pricing, it's something that really depends on your BMI and how healthy you are, and that's really what's going to be what determines the price and whether you stay overnight and it can be done at our surgery center. So I think the range we would give out there for patients would probably be, if it's an overnight stay at the hospital, somewhere around, I think it's 16,000, something like that, and then down to same-day surgery at the outpatient surgery center would be a much lower number, probably in the range of 11 to 12,000. We probably have to look over your case and see if you qualify for that. So we, I think that if insurance doesn't cover it, it's a great investment. People have no problem buying a car or a large purchase item, and they don't look at this as something like that, but it's an investment in your future, in your own health. And so I think go for it if you don't have insurance coverage. You'll get a return on that investment for the rest of your life. And the cash pay, usually we think of if you have a lot of other illnesses, that return probably would occur over about a 3-year period due to no more medication costs, no more doctor's visits, and all these things that pile up, no more loss of work. And that's how you get a return for what you pay.
Yeah, there's data that suggests that a kidney transplant pays for itself in 2 years, despite everything that goes into it with coming off of dialysis and things like that. And the only thing that I would say is analogous to that type of beneficial operation is weight loss surgery. The health impacts that it has on your life pay for themselves. And it's probably only just a few years, as Dr. Huguet said. But it's certainly an investment and a worthwhile one. The other thing that I've heard is that if patients go to Mexico and have an operation and then have a complication, insurance may not pay for management of the complication even in the United States.
Yeah, and that does come up. That's
Yeah.
a big deal. We've come across that for sure.
So it's a dangerous move and just not worth it.
You want to read that one?
Yeah, okay. Another question is, do folks generally keep the weight off 5, 10, 20 years after sleeve gastrectomy or regain it? The data supports that sleeve gastrectomy has a very good long-term weight loss profile. So I'm not sure of the 20-year data, but I know the 10-year data, 5 and 10-year data suggests that the majority of patients keep their weight off. There is a percentage of something called weight recidivism where patients will regain weight with either operation, and I would say that number is less than 10%. So in short, yes. A lot of it is multifactorial, of course, sticking to the diet and lifestyle commitment that goes with bariatric surgery, but it's very effective.
One of the things we have here at the Weight Loss Institute, we also have our bariatric practitioner / coach, and one of her roles is to help patients in those scenarios where maybe they've fallen off track, and we have a back on track program. If they do find that maybe they're making unwise choices and maybe doing some things, because and as we all know, surgery is not a silver bullet. It's one part of an entire change, and sometimes patients can lose sight of that and kind of go back to bad behaviors. And so what we like to do is think of this as more of a holistic approach, and the operation is just one component and not just one isolated thing you do. And so I think that does play a role in patients regaining weight. And so if it does occur in that small percentage, we give the support you need to get you back on track. We have a program called Back on Track, actually. Yeah. We have another question. So
I think so right now.
why? So here's a question. So what are the criteria for weight loss surgery? So those criteria are oftentimes set by your insurance company, and so we can tell you general criteria, but sometimes it comes down to whether your insurance says yes, they'll cover it, or no, they won't. I would say we base it on your level of obesity in relation to what other illnesses you have. So we use your body mass index, which is basically your weight and your height thrown into an equation to come up with a number. When you're over 40, usually that number, just that by itself with no other illnesses, can qualify you for surgery. And when it goes down to say 35 to 40, then usually we like other illnesses associated with it. Or insurance companies, I should say, like that. Things like hypertension, diabetes, sleep apnea. They've just lowered the weight limit, say, for somebody with diabetes and has a lower BMI between 30 and 35. Those are people that typically you may not think of a weight loss operation, but it's actually something that's now encouraged. If, for example, you're on medications and your diabetes seems to be getting worse and your BMI is between 30 and 35, it's now a consideration in that patient population to put your diabetes into remission, and that's actually supported by data as well as the American Diabetes Association. So we have another question.
So there's a question, what is dumping syndrome? It's a good question. So in our normal anatomy, when we eat food, it goes into our stomach. It mixes with gastric juices and gets partially digested. And then there's a muscle at the end of the stomach called the pylorus that controls emptying the stomach. And it allows small amounts of fluid and food to enter the small intestine at a time. With the gastric bypass, the small intestine is connected directly to the top of the stomach. So there's no pylorus that controls it. So if someone drinks, for example, a milkshake or something with a lot of sugar, high calorie content that enters the small intestine rapidly, then there's a large influx of insulin. And then as that content passes through rapidly, that insulin results in symptoms of low blood sugar, which can be sweating, dizziness, palpitations, that sort of thing, and diarrhea. Overall, it's transient and it's not a risk to your life, but it is unpleasant. So it's something that is best avoided. But as I mentioned before, sometimes it can serve as a positive reinforcement for maybe not eating that again. Like Rufio said.
Yeah, he supports it. All right, let's see. Maybe have time for one more question here. And it says,
About that one, we can talk, kind of lead into some of this stuff.
what should I look for in a weight loss program? And, I think it's a good question. I think the things that are important for a good weight loss program is that the program is, number one, comprehensive. You want a program that just isn't based on a surgeon by himself, but more a whole team approach to the patient, and I think more focus on lifestyle modification and an entire holistic approach or a multidisciplinary approach to patient care. And I think if we, or the program can instill that mindset into patients, I think they're set up more for long-term success. The procedure itself and the surgeons are more kind of like the captain of the ship, but there's a whole lot of other moving parts, and I think that that's something they need to look for is a program that has all of those components: a fellowship-trained surgeon, a psychologist who's devoted to bariatrics, dietitians, exercise specialists. And that's something that all programs don't offer, the exercise specialists, but I think it's important because people are often afraid to say go see them, but it's really, they're not there to put you on a really tough training program 3 days a week, which is what people are afraid of. It's more meet with them to see what you can do and then make it more something that's palatable for you so that you do want to incorporate this change in your life rather than be averse to it. So I think that's an important point too.
Yeah, and then, you know, I think most people that have come through the program have met either Megan or Hannah and immediately realize the value of having someone like a bariatric coordinator, because there's so many moving parts and it's a big commitment for the patient, and it's always best if there's someone that can answer questions and support you and, you know, put together things like this Facebook Live that kind of spreads the word and provides a lot of support within the community.
And have them on your side, somebody kind of like
Yeah.
an advocate, like you're saying, that'll help you through the whole process, and like a go-to person. We have one here, Hannah, as the advocate, and then we have another one at the hospital we work at. So there's 2 patient advocates that really guide you through the process. I think that's important.
Yeah, so like you said, a really comprehensive program, and then also, of course, just beware of the general surgeon who dabbles in it as opposed to a fellowship-trained bariatric surgeon, because it really makes a significant difference.
How are we doing, guys? I think we're getting down to about our 30-minute mark. So. Okay, well, I appreciate y'all watching today. We enjoyed our time with you, so did Rufio.
Yeah.
And we'll look forward to. One more thing, and sorry at the last minute here, our advocate is wanting us to also throw in here that not only is this all about surgery, we also offer a medical weight loss program with our nurse practitioner. And there's a couple different hats she wears. She follows our weight loss surgery patients afterwards to ensure their success and coach them. But she also has a role in treating obesity in people that maybe aren't interested in surgery, or maybe need to lose a few pounds for something like a wedding coming up, or you have a deadline, or an event where you want to have a certain weight you meet. We also incorporate her for patients that say need a different operation, like a hernia repair or joint replacement, and they have to lose so much weight in order to safely undergo the surgery. So that's more goal-directed weight loss. So I think we offer basically all components of weight management, be it medical weight loss or surgical weight loss. We offer things like B12 supplementation, and as well as pharmacotherapy to help with weight loss too. So.
Yeah, and we kind of touched on it before, but Kelly also, I think, manages the Back on Track program. So anyone who has struggled with weight regain after a prior bariatric surgery operation, the initial approach is always medical weight loss. And she's the person to help guide with that and potentially steer towards any revisional surgery if necessary. And also, Kim, call us for weight loss surgery. Call us for medical weight loss. These Post-its are just not. All right. So, so call us for information on the medical weight loss program. It sounds like you have coverage.
All right. Well, I guess we'll wrap it up there, guys. I appreciate your time today, and we'll see you on future Facebook Live events.